Welcome back to the deep dive. Imagine you're scrubbed in, contemplating that crucial final decision for your patient's total hip replacement. What factors truly guide your hand, really, beyond just the textbooks?
That's the million-dollar question, isn't it?
Exactly. So today we're taking a deep dive into precisely that. Navigating the nuances of total hip replacement techniques, understanding the invaluable data from joint registries, and making truly informed implant choices.
Yeah.
And this deep dive, it's crafted specifically for you, our orthopedic residents, as you gear up for those postgraduate exit exams like the FRCS or, equivalent fellowship exams.
We want to give you that concentrated dose of essential knowledge. Clinical pearls, really.
That's the goal, help you not just pass, but excel. And all of this is built upon the incredibly thorough Ortho-Made Simple Notes from mokyingren.sg. These were put together by Dr. Mok Ying Ren, a sports surgeon from National University Hospital, Singapore, who did his FRCS back in 2022.
That's right. Our mission today is, well, to cut through some of the noise, synthesize the key findings from these comprehensive notes, and really equip you with a robust framework. Something for understanding and applying this complex information.
Not just in theory, right?
Absolutely not. Where it truly counts,
Yeah.
in the operating room, and of course for those challenging exam scenarios.
Huh.
It's about knowing not just the facts, but why they matter to your patients and your practice.
Okay, let's unpack this then. Let's start with the foundational technical details. These are critical from the moment you even consider surgery. When we talk about femoral canal morphology, what exactly is the door classification, and why is understanding it so pivotal for our approach, especially for stem choice?
Right, the door classification. Think of it as your initial radiographic blueprint for the femur. It classifies the canal based on the ratio of the canal width to the calcar width, measured at specific points, 3 centimeters into 10 centimeters from the middle of the lesser trochanter.
Okay.
And you get 3 types. Door A is like a champagne flute canal. The ratio is less than 0.5, meaning thick cortical bone. Perfect, really, for press-fit, uncemented stems.
Right, ideal scenario.
Then there's door B, more funnel-shaped, ratio between 0.5 and 0.75. It's kind of a transitional bone type. Here you might use either cemented or uncemented, depending on other factors.
Makes sense.
And finally, door C. That's your stovepipe canal. Ratio greater than 0.75, indicating thin cortical bone. This morphology, well, it usually dictates a cemented stem. You need that stable fixation, prevents stress shielding. So understanding door isn't just academic, it directly dictates your fixation strategy. It's about minimizing early failure.
That makes perfect sense, matching the stem to the bone's unique architecture. Okay, so once we have our approach to the bone, we need to choose the actual implants. Switching gears a bit, evaluating those implants, we constantly hear about ODP ratings. So what exactly is ODP, and what are its key components that we absolutely need to internalize?
OD.
Right.
It stands for the Orthopaedic Data Evaluation Panel. It's basically your go-to for assessing implant performance. Think of it like a quality stamp almost.
Okay.
It's built on 3 pillars. First, the years of follow-up on the implant, obviously, more years, more confidence. Second, the strength of the evidence. And here, real-world, large-scale registry data is considered the gold standard, much stronger than smaller studies.
And the star. You sometimes see a star, like 10A.
Exactly. That star is crucial. An ODP 10A, for instance, means that implant has a benchmark replacement rate of less than 5% at 10 years. So an ODP 10A tells you this implant has robust 10-year data showing exceptional longevity. It's critical for predicting long-term success and, well, making truly evidence-based choices.
That 5% benchmark, that's really what we're aiming for, isn't it? And one of the biggest concerns directly impacting that longevity is wear. Our sources lay out a pretty clear hierarchy of bearing wear rates. What are the key differences we need to grasp, and what's the critical takeaway for practice?
Wear is huge. The critical takeaway here is the magnitude of difference we see now. Materials like cross-linked polyethylene, XLPE, and ceramics have just revolutionized longevity.
How big a difference are we talking?
Well, historically, conventional metal on polyethylene, MOP, showed a wear rate around 0.1 millar a year. But when we switch to XLPE, that rate dramatically drops. We're talking 0.05 millar a year, cut in half.
Wow.
And it gets better. Ceramic on ceramic, COC, boasts wear rates maybe 10 to even 100 times lower than conventional MOP, often quoted as low as like 0.00005 millar a year.
Tiny.
Incredibly low. Now, metal on metal MOM also had very low wear numbers, around 0.0005 millimere a year. But, and this is critical, Those submicron metal particles proved biologically active, caused major issues like pseudotumors. So don't be fooled by just the number there.
Right, the biological reaction is key.
Absolutely. The big picture is that XLPE and ceramic options have vastly improved wear performance, and that translates directly to longer implant survival.
It's clear the newer materials have really shifted the game on wear. Understanding those trade-offs, not just the numbers, is vital. Now, this raises a really important question when residents grapple with daily surgical approach: posterior, lateral, anterior. Which one would you typically choose, and why? Our sources highlight some strong points, but also some fascinating conflicts in the literature.
It's a common debate, isn't it?
Okay.
For me personally, the posterior approach remains my primary choice. The reasons are, honestly, quite practical. First, it's the approach I'm most proficient in from my training, and that proficiency, I believe, is arguably the most critical factor for patient safety and outcome.
Familiarity breeds safety.
In many ways, yes. Second, it's highly extensile. If you run into unexpected complications, you can easily extend your exposure without changing your whole plan. But, and this is a huge but, if you use the posterior approach, you must meticulously repair the posterior joint capsule and the short external rotators. That's non-negotiable.
And the evidence supports that.
Yes, K1 et al. 2006 systematic review show that with proper soft tissue repair, dislocation rates are actually comparable across anterolateral, direct lateral, and posterior approaches. Plus, posterior has inherent advantages like no violation of the abductor mechanism and often excellent acetabular exposure.
So the message isn't really about one approach being inherently superior overall, but more about mastering your chosen approach and being absolutely meticulous with that soft tissue repair.
Precisely. Technique trumps approach selection in many ways.
But what about the anterior approach? It gets a lot of buzz, especially regarding recovery. The data, though, seems kind of all over the place.
You're absolutely right. The anterior approach is where the literature gets, well, quite conflicted. There's just no universal consensus. The AOJ-NRR, the Australian Registry, found overall no difference in revision rates across all approaches.
Okay, so maybe it doesn't matter in the long run.
Well, hold on. Other data, like a 2020 JBJS paper by Hoskins et al., also using Australian registry data, suggested higher early major revisions for things like paraprosthetic fracture or loosening with the anterior approach. Then a Frank Stinchfield Award paper hinted at higher infection rates for anterior.
Higher infection. But didn't you say that AOJ-NRR found something else?
Exactly. To add to the confusion, the AOJ-NRR itself showed lower revision rates specifically for infection with the anterior approach. It's contradictory. Meanwhile, the Swedish and Norwegian registries showed no difference in dislocation rates for posterior versus lateral.
Okay, wow. So what's a pragmatic takeaway for a resident facing an exam question on this or trying to decide in the OR? It sounds like technique and that soft tissue repair are the true equalizers.
That's exactly it. For you as a resident, the critical insight isn't getting bogged down trying to pick a winner when the data itself is in conflict. It's understanding that your surgical proficiency, developed through dedicated training, coupled with meticulous soft tissue repair, is paramount, regardless of the approach you choose. Be aware of the varying registry findings, definitely, but ultimately, trust your training and execute your technique flawlessly.
Okay, sound advice. So once we're in, getting the implant positioning right is absolutely critical for long-term success. Lewinik safe zones are a classic teaching point, aren't they? But what's the latest thinking? Have things evolved beyond those original guidelines?
They definitely have. Lewinik safe zones from way back in 1978 were a great starting point, absolutely. Cup inclination 40 plus or minus 10 degrees, anteversion 15 plus or minus 10, we all learned those.
The classic numbers.
Right. But we now understand that dislocations can still happen, even when you're technically within these traditional zones. The concept has evolved. Dorr and colleagues proposed combined anteversion back in 2009. The idea is to target a total anteversion from both the cup and the stem, aiming for around 35 degrees plus or minus 10.
So it's the sum of the two.
Exactly. It's about the functional orientation of the entire construct. For intraoperative assessment, if you don't have navigation, the Raynaud sign can be useful.
How does that work?
With the patient stable in the lateral position, you extend the operated leg. Then, you internally rotate the leg from neutral until the base of the femoral head looks parallel to the face of the acetabular component. That angle you see, measured or estimated, gives you your combined anteversion. You're aiming for that 75 plus or minus 10 range. It's about optimizing the total prosthetic alignment, not just individual component angles in isolation.
Fascinating how our understanding of stability keeps evolving. Now, when placing acetabular screws, that always feels like a high-stakes moment. It's not just about getting them in securely, but crucially, avoiding critical structures. What's the ideal placement zone, and what are the absolute danger zones we need to be hyper-aware of?
You're right, screw placement demands extreme care. The ideal and safest spot is generally the posterior superior quadrant. If you imagine drawing a line from the ACES to the center of the acetabulum, then a perpendicular line through the center, that upper back quadrant is your target.
Okay, posterior, superior.
And the danger zones. Big dangers elsewhere. Anterior inferior quadrant, you risk hitting the obturator neurovascular bundle. Anterior superior, watch out for the external iliac neurovascular bundle. And posterior inferior, that's close to the sciatic nerve. Screws there are sometimes acceptable, but you really want to keep them short, like less than 20 millimeters, to minimize any risk to the nerve.
Avoiding those vital structures is absolutely non-negotiable. Okay, finally for this section, post-op. We've done the surgery. How do we critically assess our work on a radiograph? What are the key zones and signs we need to master to ensure everything looks stable and well-positioned?
Right. Reading that post-op film is a core skill. For the femoral stem, we use the Gruen zones. There are 14 zones around the stem, helping us assess fixation and look for any signs of subsidence or loosening over time. The stem tip, for example, usually sits down in zones 7 and 11.
14 zones for the stem. What about the cup?
For the acetabular cup, we typically use the Daly and Charnley zones. There are just 3 zones here, mainly looking at the cement mantle if it's cemented, or looking for radiolucencies, which might indicate loosening.
And specifically for cemented versus uncemented.
Good distinction. For cemented implants, we use the Barrick and Harris grading system. This looks at radiolucency at the cement bone interface. Grade A is perfect, complete filling. B means less than 50% radiolucency at the interface. C is more than 50%. And D is bad news, a complete 100% radiolucent line suggesting failure.
And for uncemented?
For uncemented, we're looking for signs of biological fixation. Things like spot welding, which is that direct industrial bone contact with the porous surface of the implant. It looks like the bone is grabbing onto it. And crucially, you want to see no subsidence or movement on serial radiographs taken over time. That indicates stable bone in growth.
That's a really comprehensive checklist for assessing the immediate outcome and anticipating potential future challenges. Invaluable stuff. Just a quick reminder, you're listening to The Deep Dive, and this deep dive is based on the excellent Ortho Made Simple notes from mokyingren.sg. Okay, part 2. Here's where it gets really interesting, I think. We've mentioned joint registries quite a few times already as sort of the gold standard for evidence. For those residents perhaps less familiar, what exactly is a joint registry and how did they become such a cornerstone of modern orthopedic practice?
Right, registries are fundamental now. A joint registry is essentially a huge longitudinal database. It systematically collects data on specific joint replacement implants, the surgical details, and patient outcomes, primarily revision, from all participating surgeons within a defined region or country. It's an all-comers approach, capturing real-world results, not just select patients in controlled trials.
And they've been around a while.
Yes. The oldest and perhaps most famous is the Swedish Hip Registry, started way back in 1975. They were real pioneers. The UK National Joint Registry, the NJR, established in 2002, is now the largest in the world. They basically evolved out of a critical need to track implant performance systematically and detect problems early, beyond what any single surgeon or hospital could possibly do alone.
That comprehensive real-world data sounds incredibly powerful. But like any tool, they must have strengths and weaknesses. What are the key uses, the undeniable strengths, and importantly, the known limitations or cons of these registries that residents really need to keep in mind when interpreting the data?
Absolutely. Critical appraisal is key. Their uses are incredibly broad. Hospitals use them to benchmark and spot trends. Individual surgeons like us can track our own revision rates, compare ourselves anonymously to peers, and hopefully refine our techniques. Implant companies rely on them for crucial post-market surveillance, identifying and recalling faulty implants much faster. And for researchers, they provide these massive data sets for survival analysis and identifying risk factors.
And the main strength?
The main strength is undoubtedly the sheer scale of the data. Millions of procedures in some cases. This large sample size helps overcome the biases inherent in smaller studies or single-center reports. But they definitely have limitations.
Such as?
Well, historically, the primary outcome studied was revision surgery. So a patient might be unhappy, have pain, or poor function. But if they don't get revised, that failure might not be captured. Also, many registries traditionally lacked detailed patient-reported outcome measures, PROMs, or specific radiological data, although the NGR and others are increasingly adding these, which is great.
Data quality issues too, I imagine.
Yes, data entry quality can be a challenge. Missing data, unlinked procedures, accurately capturing patient complexity or case mix, these are persistent issues. And crucially, because they capture all-comer data, the results reflect the average performance across all surgeons, not necessarily the outcomes achievable by high-volume specialists or centers of excellence. And of course, they're very expensive to run and maintain.
Right. So registries are incredibly powerful, but we have to interpret their findings with a nuanced understanding of these limitations. You mentioned recalling faulty implants, and there's a specific incident of sort of cautionary tale that really spurred the widespread use of registry data. Can you tell us about the 3M capital hip?
Ah yes, the 3M capital hip. It's a classic case study really taught in orthopedics for a reason. This implant was marketed roughly between 1991 and 1997. Concerns about its performance started bubbling up around 1995. Initially, a surgeon survey suggested a 5% revision rate. Remarkably, the company apparently dismissed this at first, calling it sort of industry standard.
Wow.
Yeah. But thanks to continued monitoring and accumulating evidence, the kind registries are designed to gather, the high failure rate became undeniable, and the device was eventually withdrawn from the market. This whole episode starkly highlighted the critical need for independent, systematic data collection. It showed how registries could identify poorly performing implants early, potentially protecting thousands of patients. It was a real catalyst for the systems we have today.
A very stark reminder of the power of systematic data collection and vigilance. Okay, now let's dive into some of the most critical takeaways from the registries for residents preparing for exams. What do the big ones, like the AOJNRR you mentioned and others, actually tell us about THR outcomes based on things like why the patient needed the hip replacement or the implant characteristics? These are the insights that really shape our day-to-day decision-making.
Absolutely. This is where the rubber meets the road. The registry data offers some really clear guidance. Let's break it down, starting with fixation choice based on the reason for surgery, the etiology.
Yep.
So for femoral neck fractures, NOFCHAP, if the patient is under 70, the AOJNRR shows no significant difference in revision rates between hybrid fixation that's usually an uncemented cup and a cemented stem versus fully cementless fixation.
But over 70.
Big difference. For patients over 70 with a neck of femur fracture, cementless fixation shows significantly higher revision rates than hybrid fixation. There was no difference found between hybrid and fully cemented, though, the takeaway. For older patients with potentially weaker bone from a fracture, being cautious about relying solely on uncemented fixation, especially for the stem, seems prudent. Hybrid often performs better.
Got it. And what about for osteoarthritis of it? Does age matter there too?
It absolutely does. For osteoarthritis, OA, across all age groups, hybrid fixation generally has lower revision rates than cementless. But digging deeper, for patients under 55, there's actually no significant difference between cementless and hybrid. Younger bone, better ingrowth potential perhaps. Between 55 and 64, no difference between cemented and hybrid. But for patients over 65, cementless starts showing higher revision rates than hybrid. And critically, for patients over 75, cementless has higher revision rates than both fully cemented and hybrid fixation.
So that age threshold around 65, 75 seems really key for fixation choice in OA.
It really does. As bone quality likely declines with age, the reliability and immediate stability offered by cemented or hybrid fixation, particularly on the femoral side, seem to become more advantageous according to the registry data. It's a crucial distinction for managing your older patient population.
Definitely. Okay, what about bearing surfaces and head size? What do the registries tell us there?
Some really important findings here too. XLPE versus non-XLPE. Cross-linked polyethylene is just a clear winner. The data shows that after just 6 months post-op, XLPE already has a lower risk of revision compared to the older non-cross-linked poly. And the difference magnifies over time. By 18 years, the revision rates for non-XLPE were literally double those for XLPE, think 14% versus 7%. The message is clear. Always prioritize XLPE for its superior wear and longevity.
That's a massive difference.
Huge. Now, comparing the modern bearing surfaces, when you look at the high performers like XLPE on metal, MOP, ceramic on ceramic Co-C, or ceramic on XLPE Co, the long-term registry data, like from Australia at 15 years, shows fairly similar revision rates around 6–7%. However, metal on metal, MOM, was a disaster, with revision rates hitting 30% versus 6% at 15 years. It underscores why MOM is rarely used now.
And head size. There was that debate about bigger heads for stability versus wear.
Yes, and the data is quite specific. The optimal balance seems to be around 32 mm head size. The Australian Registry, for example, found that 32 mm heads had a significantly lower revision rate at 14 years, about 4.6% compared to 36 mm heads, which were up at 8.5%. Smaller heads, less than 32 mm, also had higher revision rates.
So 32 seems to be the sweet spot.
It really looks like it from the registry data. Larger heads might offer a bit more stability in theory, but they seem to come with a penalty in terms of long-term revision rates, likely due to wear or edge loading issues. So aiming for 32 mm appears to offer the best balance based on current large-scale evidence.
What about approach, again, just to confirm the registry take?
Right, as we touched on earlier, the overall AOJ-NRR finding was no significant difference in the overall revision rate across all the common surgical approaches, posterior, lateral, anterior. This really reinforces that idea we discussed. Surgical proficiency and meticulous technique are likely more important drivers of outcome than the specific approach chosen, at least when looking at revision as the endpoint in large data sets.
This really raises an important question, then. How do these impressive THR survival rates stack up against other common joint replacements? It gives us a crucial sense of perspective, doesn't it, on just how good a procedure total hip replacement actually is.
It absolutely does, and it's really a testament to the pioneers and the ongoing refinement of the procedure. Total hip replacements consistently show a remarkable 10-year survival rate of around 95%. That puts it right at the top.
How does that compare?
Well, total knee replacements are also excellent, right up there at about 95% survival at 10 years. But compare that to, say, total ankle replacement, which is much lower, around 77%. Total elbow arthroplasty sits around 88%. Reverse shoulder arthroplasty is pretty good, about 94%. Similar for anatomical total shoulder at 93%. And things like high tibial osteotomy or unicompartmental knee arthroplasty are often quoted around 80% survival at 10 years.
Wow, so 95% for THR and TKR really stands out. That truly reinforces THR's outstanding track record. It's one of the most successful and impactful surgical procedures we perform in orthopedics.
Without a doubt.
Yeah.
A real game changer for patients with debilitating hip arthritis.
Okay, part 3. So armed with all this detailed technical knowledge and this deep understanding of what the registries tell us, how do we synthesize it all? How do we form a coherent, defensible strategy for implant choice? What's the guiding principle you'd advise residents to adopt, especially for their exams and, more importantly, for their future practice?
That's the key question, isn't it? How to put it all together. My guiding principle, and what I'd recommend articulating in an exam setting, is this. My implant choice is based on a careful integration of basic science principles, my own surgical training and proficiency, and robust large-scale registry data. And then I'd structure the answer, categorizing it by fixation type, bearing surface, and head size.
Okay, a 3-pronged justification. Let's explore that structure, starting with fixation. Based on those pillars, science, training, registries, what's your preferred approach for fixation, and what's the detailed rationale?
So, following that framework, I typically lean towards hybrid fixation for total hip arthroplasty. This preference stems, firstly, from my comfort and extensive training with this method that's the training and proficiency pillar. I know how to execute it well.
Right.
Secondly, it aligns with basic science principles and registry data. Let's break down the components. For the acetabular cup, my preference within a hybrid construct is cementless. While systematic reviews often show no significant long-term survival difference between cemented and cementless cups, basic science tells us cement is weaker under shear stress. A cementless cup allows for biological integration, potentially avoiding those shear stresses at the interface.
Makes sense biologically. And the stem.
For the femoral stem in a hybrid construct, my go-to is typically the Exeter taper slip stem. This is a cemented stem. Its design principle is force-closed, meaning it allows for controlled microsubsidence within the cement mantle, which is a very well understood and highly successful mechanism for load transfer over decades. That's the basic science part.
And the evidence.
The evidence is incredibly strong. The Exeter stem boasts an ODP 15A rating. That signifies over 15 years of robust registry data, showing less than a 5% revision rate at 10 years. That's top-tier evidence supporting its longevity. That's the registry data pillar.
And how does the registry data on hybrid versus other fixations, especially considering age, support this choice?
That's where it gets really compelling. As we discussed, the Australian registry found no difference in revision rates between hybrid and fully cementless for patients under age 64. But, and this is critical, for patients over 65, cementless fixation shows a higher revision rate than hybrid. And this difference becomes even more pronounced for patients over 75. Remember those 15-year revision rates. 7.9% for cementless versus 4.9% for hybrid.
So the age factor really pushes towards hybrid or cemented in older patients.
Exactly. For older patients where bone quality might be compromised, the immediate reliable fixation provided by a cemented stem as part of a hybrid construct appears superior according to large-scale registry data. So my preference for hybrid balances the benefits of biological fixation on the cup side with the proven reliability of a cemented stem in potentially weaker bone, especially in older patients.
That's a really crucial nuance to understand. Age and patient factors significantly influence that fixation choice. Even if overall survival looks similar in certain younger groups, it's definitely not one size fits all. Okay, moving on to the bearing surface. What's your go-to choice here, and what are the considerations with the alternatives?
For the bearing surface, my preference, again based on the evidence, is metal on XLPE, cross-linked polyethylene, for essentially all age groups. The justification comes straight from the registry data we talked about. It's demonstrably superior wear properties and significantly lower long-term revision rates compared to the older conventional non-XLPE on metal. Remember that 15-year data. 6% revision for XLPE versus 11% for non-XLPE.
That's hard to argue with. What about ceramic options?
I'm certainly aware of the alternatives, primarily ceramic on poly cup or ceramic on ceramic koki. They have excellent low wear rates too. However, they come with potential trade-offs. Ceramics, particularly koki, tend to be more expensive, and koki has unique, albeit relatively uncommon, failure mechanisms. You need to be aware of things like squeaking, the risk of edge loading or patch wear, and that small but devastating risk of catastrophic fracture.
So why XLPE over ceramic, given the registries show similar revision rates sometimes?
It's about the overall balance. While the big registries, like Australia's, show similar 15-year revision rates across modern MOP using XLPE, COPE, and KOKI, around 5–7%, the proven track record, lower cost generally, and avoidance of those specific ceramic failure modes make metal on XLPE my preferred workhorse bearing. It offers an excellent combination of low wear, proven longevity, safety, and cost effectiveness.
Okay, a pragmatic choice based on balancing multiple factors. Finally, head size. We know it's a crucial balance between stability and wear. What's the ideal target size based on the data?
Head size selection is indeed about finding that optimal balance. Larger heads theoretically improve the med-neck ratio, which can increase the range of motion before impingement and potentially reduce dislocation risk. However, they also increase the surface area for wear and potentially the volumetric wear rate, depending on the bearing couple.
So where does the evidence point?
As we discussed, the robust Australian registry data strongly suggests that revision rates are lowest with a 32mm head size. Both smaller heads, less than 32mm, and larger heads, greater than 32mm, like 36mm, showed higher revision rates in their long-term data. Therefore, my aim is typically a 32mm head, as it appears to offer the best compromise achieving good stability while minimizing the long-term revision risk seen with other sizes in large registry cohorts.
We have covered a tremendous amount of ground today. Wow. From the technical specifics like door classification, ODEP ratings, the nitty-gritty of wear rates and surgical approaches, including positioning and screw placement.
All the way through to understanding radiographs.
Exactly. Then we journeyed through the power, but also the pitfalls of joint registries, seeing how that 3M Capital hip story shaped things, and how registries reveal those critical insights for different patient demographics and implant types.
And finally, pulling it all together.
Right. Synthesizing all of that into a logical, evidence-based framework for making informed implant choices, thinking about fixation, bearing surface, and head size. This deep dive should be, I hope, an invaluable resource as you prepare for your exams and your future practice.
And perhaps a final thought to leave with our listeners, something to ponder. Given how quickly new materials, techniques, and especially the data from these evolving joint registries emerge, how might our current ideal implant choices continue to shift in the next decade? And maybe more importantly, what role will you, as the future generation of orthopedic leaders, play in critically evaluating this new evidence and actively shaping those future standards of care?
That's a profound question indeed, and one that really highlights the continuous journey of learning and adaptation that defines orthopedics. We truly hope this deep dive has provided you with invaluable knowledge for your upcoming exams and, even more importantly, for the patients you'll care for throughout your career. And remember, this deep dive was based on the excellent Ortho Made Simple notes available over at mokyingren.sg.
Keep questioning, keep learning.
Absolutely. And as you continue on your journey to master this challenging yet incredibly rewarding field, remember this blessing. Whoever brings blessing will be enriched, and one who waters will himself be watered. That's from Proverbs 11.25. Keep learning, keep pushing yourselves, and keep striving to bring blessing to your patients and your communities. You've got this.